This is Dr. Ahmed, the Assistant Professor of Radio Diagnosis and Interventional Radiology in Ain Shams University Hospital, Cairo, Egypt. In today's lecture, I'll be discussing the ultrasound of the shoulder joint, the main technique, and the most common pathologies. First of all, we've got to have a review about the common uses of the ultrasound in musculoskeletal imaging. We use the ultrasound in detection of the tendinous pathology of the shoulder, knee, ankles, and any other joint, detection of ligament and muscle tears, assessment of fluid collection and superficial masses. It has a main role also in rheumatoid arthritis screening, particularly in detection of erosions and synovial hypertrophy. Also, nerve entrapments, most common nerve entrapment, of course, is the carpal tunnel. Detection of foreign bodies, ganglion cysts and hernias, and of course the ultrasound guided procedures, either in aspiration or biopsies, or even the treatment injections, I mean. One last important pediatric use of the ultrasound is for sure of the detection of hip pathologies in children, mainly the DDH and joint effusions. Regarding the limitations of ultrasound, the ultrasound waves usually does not penetrate the bone. All we can see is that is the outer surface of the bone and the outer aspect of the examined joint. However, in children's and infants, they have more cartilaginous structures and non-ossified bones. Thus, this makes us go deeper by the ultrasound waves and get more details. Regarding the proper assessment of the joint, it's more preferable to do an MRI. Another limitation is the depth of the ultrasound waves, mainly in obese patients, which may give some difficulty just to assess the examined structure. In these cases, we usually use the curvilinear probe rather than the superficial probe to get as much information as possible. Last thing is that it's an operator-dependent examination, so it depends on the skill and the experience of the operator. So basically, we use the superficial high-frequency probe, usually from 7 to 12 megahertz. This probe gives us a very high resolution to get a detailed information about the fine anatomical structures of the examined joints. Some important points that we must put in mind during the examination is that clinical history is very important to detect the normal anatomical location of symptoms and pain. Secondly, contralateral comparison is very important also, as it helps us to detect minor injuries that can be easily missed without doing a comparative study. Third, we can use compression by the transducer, and this can help us more or less know the nature of the underlying lesion, whether it's solid or cystic, or whether it is a turbid collection or a solid lesion, together with the use of the color Doppler ultrasound to assess the vascularity of the examined structures. And this also helps us avoid these vascular structures or know the nature of the lesion, particularly before using in the interventional procedures. Last thing that we must be aware of the artifacts and pitfalls of the study, which is mainly the anisotropy. So anisotropy is a common artifact seen in musculoskeletal imaging when the examined structure is not in a perpendicular angle with the ultrasound beam. This can result in a hypoechoic image of the examined tendon or structure, and this can just mimic a tear or a fluid collection. So you must be aware about this artifact. So passing to our topic today, the rotator cuff of the shoulder is composed of four muscles: the supraspinatus, infraspinatus, teres minor, and subscapularis. The subscapularis usually is involved in internal rotation, the infraspinatus and teres minor in external rotation, and the supraspinatus in abduction, which is the most commonly injured tendon. The rotator cuff muscles usually depress the humeral head against the glenoid. So in cases of rotator cuff tear, the humeral head usually migrates upwards against the unopposed action of the deltoid muscle. So the supraspinatus muscle arises from the suprascapular fossa and inserts into the greater tuberosity. The infraspinatus muscle arises from the infraspinous fossa and inserts also in the greater tuberosity, as well as the teres minor muscle also inserts in the greater tuberosity. The subscapularis muscle is the only one that inserts into the lesser tuberosity. It arises from the subscapularis fossa. In ultrasound, we examine the long head of the biceps tendon, which inserts in the supraglenoid process, while the short head inserts into the coracoid process. So regarding the examination of the shoulder, we examine the biceps tendon, the rotator cuff, the bursae, the acromioclavicular joint, and glenohumeral joint. Actually, the labrum is not properly examined by the ultrasound, and it's much more better to refer it for MRI examination. So as said before, it's used for diagnostic assessment of rotator cuff tears or any shoulder lesions, as well as ultrasound guided injection or aspiration. This is the examination of the biceps tendon in transverse view and longitudinal view. In TS view, we see that the biceps tendon is seated in the bicipital groove with the thin transverse humeral ligament passing above it. This is the deltoid, skin, and subcutaneous tissue. In LS view, this is the normal appearance of the tendon with normal fibrillar pattern. We've got to assess the thickness and the normal fibrillar pattern of the tendon to assess whether is there any tendinopathies or tears. Another important point is that the biceps tendon sheath is in continuity with the shoulder joint. So in cases of shoulder joint effusion, we can see the fluid extending to around the biceps tendon. This makes us move to another differential diagnosis, which is the tenosynovitis of the biceps tendon that is also associated with the fluid around it. A main differentiating point is that in cases of tenosynovitis, we will find the tendon more thickened. We can use a comparative study with the other side. Also, we can find increased vascularity on Doppler study. Moreover, the effusion from tenosynovitis is usually not compressible during the compression that we can use in our study, as mentioned before. Regarding the examination of the subscapularis tendon, we just move the probe medially after examining the biceps tendon. For proper assessment of this tendon, the patient is asked to do an external rotation where he keeps the elbow adjacent to his body and externally rotate his arm. This allows us to examine the full length of the subscapularis tendon and not to miss any pathology. Regarding the supraspinatus tendon examination, I prefer to put the probe over the AC joint and slide it anteriorly till I see a tendon. The first tendon seen in this region is the supraspinatus tendon. All the tendons are examined in TS and LS views in order not to miss any pathology. Here regarding the anatomy, there is the skin, subcutaneous tissue, the deltoid muscle, and a potential space here which is the subacromion subdeltoid bursa. In case of fluid seen in this region, it's called bursitis. And beneath it is the supraspinatus tendon. Here is an image for the examination of the supraspinatus tendon in TS view. Then, regarding the infraspinatus tendon examination, we feel the spine of the scapula and just put the probe inferior to it, slightly laterally. We can see the infraspinatus tendon and its insertion into the greater tuberosity. The patient is asked to put his hands on the shoulder or do a similar external or internal rotation movement to see the motion of the tendon. Superiorly, we'll examine the AC joint for any effusions for osteoarthritic changes. Normally, we see a little bulge of the capsule, which is accepted and seen on in all patients. After examination of the AC joint, we can move the probe laterally on the superior aspect of the shoulder till we see the acromion. By the end of the acromion, we see here that there is a space between the acromion and the humeral head, which is known as acromiohumeral distance. This distance is normally measured between 8 to 12 millimeters. In case it is decreased to about 6 millimeters, this indicates a sure injury of the supraspinatus tendon, mostly partial thickness tear. So it must be examined properly. Here is an example for the examination of the posterior shoulder using the Calvinian probe. We see here the skin, subcutaneous tissue, deltoid muscle, the infraspinatus tendon, and infraspinatus muscle, as well as the humeral head covered by a hypoechoic cartilage. Here we see the posterior joint, glenohumeral joint, with the echogenic triangular labrum, posterior labrum mainly. So if we just move the probe medially after examination of the infraspinatus tendon and then turn it a bit clockwise, we can see the suprascapular notch. By adding a Doppler study, you can also see the suprascapular artery and maybe the vein. This is a very important site to be examined, as the presence of a ganglion cyst here or any lesion can lead to compression of the suprascapular nerve that will lead to supraspinatus and infraspinatus muscle atrophy. Also, it's very important to use the Doppler study in cases of ultrasound-guided intervention regarding the suprascapular nerve block. This is a video for the examination of the whole technique. This is a TS view of the biceps tendon in the bicipital groove, the lesser tuberosity, the greater tuberosity, the transverse humeral ligament. Medially here is the subscapularis tendon, which is examined properly after external rotation. We notice here that the tendon shows some hypoechoic areas, which is the anisotropy artifact, so as not to be misinterpreted as fluid or tears. If we go medially, as we mentioned before, this is the subscapularis tendon after external rotation. This allows us to do a full examination of the tendon. This is the coracoid process. We notice here that there is no impingement in this dynamic study. This is the biceps tendon, an LS examination of the tendon. We notice here the normal fibrillar pattern of the tendon with no appreciable fluid around it. This is how we do the external rotation for the examination of the subscapularis tendon. For the examination of the supraspinatus tendon, patient is asked to put his hand in his waist. This is the tendon, and this is the side of the subacromial subdeltoid bursa. The tendon have curved course of its fibers, so we must examine it properly. These dark areas are usually also the anisotropy artifact, so proper assessment must be done to detect if there is any minor tears or injuries. Regarding this examination of the tendon, patient does what we call contracture stress test, where he pushes his hand against the examiner's hand like this. This allows us to detect if there's any minor injuries or tears in the tendon. Here is an LS examination of the supraspinatus tendon, and this is the biceps tendon in the rotator interval, which is the space between the supraspinatus and subscapularis tendon. This space contains the coracohumeral ligament and the superior glenohumeral ligament. Posteriorly, we examine the infraspinatus tendon just inferiorly to the spine of the scapula and a little bit laterally to see its attachment. The patient can do an external and internal rotation, which is a dynamic examination to see the proper motion of the tendon. This is the tendon. Here is the joint capsule or the joint aspect recessed posteriorly. Patient is doing an external and internal rotation for proper assessment of the tendon. This is the glenoid and the glenoid labrum. Joint effusion is seen in this area also. Superiorly examine the acromioclavicular joint. Also, ultrasound guided procedures play an important role in treatment of shoulder pain, as guided bursa injection or AC joint injection by steroids. Here we see the needle in the AC joint, and this is another example of the needle going to the site of the bursa for injection of steroids, mainly in patients with bursitis or supraspinatus tendinopathy. This is an example for the tear of the supraspinatus tendon, full thickness tear with a gap filled with fluid. We need to measure the gap for the physician. This is another example of a difficult tear to be seen, but we notice here that there is some areas of hypoechogenicity with a linear band seen beneath it. Normally, this appearance is not seen in normal individuals. This linear band represents the upper aspect of the cartilage, which is not seen except if there is a fluid above it, causing an acoustic enhancement that allows us to see it. So this is an indirect sign that here is there is a partial thickness tear that may be so challenging or difficult to see by ultrasound. Here is another example of full thickness tear of the supraspinatus tendon. This is an example of joint fusion in the AC joint. And this is an example of the joint effusion seen through the posterior aspect examination. And this is the infraspinatus tendon and muscle. Another most common pathology by far is the calcific tendinitis, where we see calcifications in the supraspinatus tendon mainly, with increased thickness of the tendon. This is an example of a ganglion cyst seen in the suprascapular notch, causing entrapment of the suprascapular nerve. Sometimes in the suprascapular notch we see a cystic lesion, and it is very important to differentiate whether it's a ganglion cyst or a capacious suprascapular vein. The main differentiating point is that when we do an external and internal rotation of the arm, normally the vein compresses and returns to a normal size during this movement, and this does not usually happen with ganglion cysts. Also, the Doppler study may be difficult to detect sluggish flow in a capacious vein, so the dynamic study is the main differentiating point. Thank you.